I hate the term game changer, but I really think that that study really is a game changer.
So in DB-05, again, this was a high-risk group of patients. These were people you thought were inoperable up front. They had T4 lesions, they had N2 or N3 lesions, and of course HER2 overexpressing, or they were node positive after you gave them, I mean, everyone got a taxane after a taxane trastuzumab-based therapy. So how are you currently kind of treating those patients right now?
Well, in the absence of a health authority approval for Trastuzumab Deruxtecan, the standard of care is TDM1 per the KATHERINE study. And I think that's been our standard of care for a long time for patients with residual disease, no matter what their clinical features were up front. So that has been our standard of care, but I'm excited to be able to offer 14 cycles of Trastuzumab Deruxtecan to those patients instead, given how incredible the DESTINY-Breast5 data looked.
So DESTINY-Breast5 had a hazard ratio of 0.47, I think. I mean, it reminds me of when KATHERINE came out. We were so excited when KATHERINE came out, partly because that was a very novel concept at the time, but also because these high-risk patients, we want to be able to offer something different. So 14 cycles of Trastuzumab Deruxtecan versus 14 cycles of TDM1 in this post-neoadjuvant with an improvement already in invasive disease-free survival.
Right. And I hate the term game changer, but I really think that that study really is a game changer in my mind. And that's the drug I want to get access to for those high-risk patients. And I think the struggle, as we've already alluded to, is around who to give these amazing novel generation antibody drug conjugates to and when. So I would be very comfortable giving Trastuzumab Deruxtecan to patients with residual disease, especially those who are young and otherwise high risk, and then we'll perseverate over what defines high risk, of course, because I might think that a 25-year-old patient with node-negative disease, but a sizable tumor is high risk for a variety of reasons. But I think accessing, I can wrap my head around accessing that novel strategy in the adjuvant setting a little bit more easily than I can in the neoadjuvant setting. Also, I appreciate your comments about
No, I think the flip side of it is to treat with maybe less toxicity, maybe a Compass HER2 regimen, get as many as you can PCR rates, and then know the biology of the people who need adjuvant therapy, and then give your best agent to the people whose biology showed you they need it.
Exactly, and that's where I'm at. And then we can further complicate the conversation by extrapolating from patina, and we're going to see HER2 CLIMB-05. Should we be throwing in CDK4/6 inhibitors too in that population?
Or oral TKIs.
Or an oral TKI.